Hello, everyone, and welcome to the third seminar in the Global Leaders in Implementation Science series at McGill University. My name is Guillaume Fontaine. I'm an assistant professor and director of the RISE lab at McGill's Ingram School of Nursing. So today we have the privilege of welcoming Dr. Natalie Taylor. She serves as the Director of Implementation to Impact and Scientia Associate Professor in the School of Population Health at UNSW Sydney, Australia. She leads a multidisciplinary team dedicated to advancing the efficient integration of research evidence into routine healthcare practice. Over the course of her career, Dr. Taylor has secured more than $72 million in competitive research funding and has forged strong collaborative partnerships across academia, government, and industry. She currently spearheads an MRFF Rapid Applied Research Translation grant focused on embedding precision oncology into standard cancer care, alongside two additional MRFF studies looking at novel technologies and their integration into the Queensland Newborn Screening Program. Her capacity as the Director of Research for the School of Population Health, Dr. Taylor shapes the school's research agenda, and she established the first master's elective in implementation science in Australia. Dr. Taylor's contributions have been recognized with multiple prestigious awards, including the Premier's Excellence Award in Translational Cancer Research, the Peter Baum Research Impact Award in 2021, and the Premier's Award for Cancer Researcher of the Year. So today she's going to present on her journey as an implementation scientist and on how to balance intuition and theory in implementation science on the basis of what she has learned. So please join me in welcoming Dr. Taylor.
Thanks so much, Guillaume, and thanks everybody for having me here today. I've been here for a couple of days now, and I'm really enjoying seeing the sights of this beautiful city. Thanks to Guillaume. So before I start, I just want to say thank you to my healthcare professional and patient participants. Without them, I couldn't do the work that I do, and yeah, just really appreciate that. You can call me Nat. Guillaume talked about the positions that I hold, but my contact details are there if anyone would like to reach out. And just some Nat stats. So I'm from England originally, as you can probably tell from my accent, and I moved to Australia in 2013 after working at the NHS after my PhD, and have been in various places of employment, all amazing and incredible experiences, and now I'm based at the University of Sydney. This is my lovely team. A few people I'll call out: April Morrow with the white shirt on there, and Jeff Chan with the blue shirt and glasses. Two people on the team who I will call out as part of some of the work that I'm going to talk about today. But in general, we have a really happy culture. That's what we try to foster as much as possible, alongside all of the hard work that we do. And this is just an example of many of the projects that we have and have had over the past 7 or 8 years and into the future. But really the point of this is just to say we are pretty clinical area agnostic. We work on lots of different projects to support the translation of evidence into practice. And that's a real benefit in the sense that we can be involved in lots of different things, and that doesn't restrict our opportunity, but it can also come with challenges around how much your brain has to stretch to think about all these new clinical areas. As Guillaume mentioned, I lead a couple of major grants. One is called NeoScreen. We've got 2 grants that support this project to introduce new genomic technology into routine newborn screening in Queensland. And we've got a couple of early publications out of that work that really focus more on establishing a better foundation for delivering consent and collecting consent for newborn screening, particularly when introducing new genomic technology. But lots of interesting work to come in that space in terms of thinking about, what kind of conditions might be added, and the care pathways that would be involved in treating children at a very young age, where that wouldn't have been the case before. So some really interesting work going on there. And then the Precision Care Initiative. So this is another big project that I lead to integrate precision oncology into routine cancer care. It's about 2.5 years through. We've established a clinic through a co-design process with clinicians, and using implementation frameworks really at the foundation of everything that we do. We've had about 120 patients through so far, and we're starting to see some really nice feedback, and I guess kind of the wheels are really kind of churning with the clinic, and we feel like we've really got a solid foundation for then embedding research into the next steps in terms of assessing the effectiveness of the clinic, and also the implementation approach that comes with that. So very excited about all of the different pieces of work that happening with that. And there is a little QR code if you want to visit the website and learn a bit more about all of the things that we're doing there. So I guess a big part of what I've worked on over the past kind of 15 years has been to really understand and engineer change. And a lot of the work has really had a foundation of, in the most simplest of forms, understanding barriers and designing strategies. And probably been involved in over 50 studies since 2008 that have tried to, kind of understand that, or actually try and apply the methods to affect practice, mainly in patient care and a little bit in health promotion. And the theories and the frameworks I tend to use have been the TDF and BCTs, and then CEPA and ERIC, obviously, when that was kind of later introduced. And I really like working with the Proctor outcomes framework as well. So kind of where it started was in health promotion, did my PhD, and I guess it's good to say here, I wanted to kind of say a bit about the journey that I'd been on in order to kind of help people to understand why I'd gotten to the way I've been thinking about intuition and theory. So it's a little bit of a journey, and hopefully it'll all kind of piece together at the end. But I've really got this health promotion space that I started off with, promoting physical activity, and then really trying to advance theory and then also apply it to elicit behaviour change for those who are facing particular barriers to be more active. And one of the really nice pieces of work out of this was a meta-analysis, which looked at the impact of theory on the effectiveness of worksite physical activity interventions. And in the early days, when there was a taxonomy of only 26 behaviour change techniques, we looked to assess the extent to which these techniques were found, and then whether or not they were effective in these kinds of interventions. And we also, through the meta-analysis kind of process, picked up this paper around whether or not interventions were theory-based, and used just a component of that kind of checklist to see to what extent the interventions that we were assessing had been designed according to explicit theory, and then kind of a longer spectrum of no theory at all, and kind of things in between. And what we found was that there wasn't really any kind of differences in effect sizes between studies that had used individual BCTs or with studies that had used more techniques than others. But there was a significant effect of those interventions that had explicitly used theory in their design. And so this was kind of a starting point for me for getting really interested in the impact of theory. As part of this work, I also developed a physical activity questionnaire to really understand the barriers that people face to physical activity. And this was based on the original theoretical domains framework, with a few adaptations, adding in action planning and coping planning and goal conflict as additional determinants. And that's been quite nicely used in a few different contexts, Canadian individuals with spinal cord injury, severe mental illness in Ireland, promoting physical activity in bladder cancer patients in Belgium. So really nice to see, you know, kind of a diverse range of population groups and settings where this tool is being used. And as part of the PhD, I used the questionnaire in an RCT to compare tailored resources designed using matched behaviour change techniques according to key TDF identified barriers in the intervention arm versus generic knowledge-based support in the control arm. And these are some of the leaflets that were sent out to all the students who were involved in the trial. And even though I didn't publish this in the end, I was explaining to Guillaume yesterday, back in the day, you had to do your thesis, then publish your publication separately. And I think this was one that was just, it kind of fell off the wagon, so to speak. But the really nice thing about it was that the NHS approached me and asked me to design some of these leaflets for some other health behaviours, so diet, smoking, I think there was one other. So there was kind of a bit of translation as a result of that, which was really nice. So then there was kind of a patient safety pull and an introduction to implementation science. I, after my PhD, I had this opportunity to implement patient safety alerts, and one of the things that they were looking for was to use a theory-based approach. So I took the TDF and how I'd used it in physical activity, and then started to look at applying it to implement 4 different patient safety alerts. One in particular was reducing the harm caused by misplaced nasogastric feeding tubes in adults, children and infants. And so this was very much an implementation practice job that I had, but I really wanted to try and understand how, you know, how could I advance the theory at the same time and really start to build my track record in the academic space as well. So just kind of going into a bit of detail around this, nasogastric tubes for feeding should be inserted and feeding commenced during daytime hours. All steps must be recorded in the care plan. Tubes mustn't be used for feeding until in a safe position. And the first line method for confirming that should be to obtain an aspirate with a pH of a particular level. And then if you can't get the aspirate, or if the aspirate's not within that kind of criteria, you would send for an X-ray. And what we found was that a lot of the healthcare professionals in 3 of the hospitals that we worked in were either just immediately sending the patient for X-ray without checking the pH, or even asking the radiologist to do the position check and confirm that position for them. So there's a lot of patients traveling around the hospital, waiting long times to be fed, and then obviously once the patient comes out of the radiology suite, that, you know, if the gold standard of the tube is you know, potentially lost. So we adapted the TDF to incorporate an implementation principles. So we had about 7 or 8 implementation principles that were kind of wrapped around the TDF to really ensure that we were understanding the context and applying you know, principles around, you know, understanding what processes look like through this particular behaviour. You know, acknowledging the complexity of behaviour change, ensuring we use co-design, and we started with representatives from all staff groups involved in this process. And what we found was that the target behaviour, based on audits and some discussions at that time with the healthcare professionals, is that they weren't using pH as the first line for checking the tube position. So we use this kind of stepped process to get this target behaviour confirmed, identify barriers, confirm them and generate strategies, support the staff to implement through a joint approach, and then evaluate through re-auditing. And as part of this, we developed the patient safety influences on patient safety behaviours questionnaire. And the really nice thing about this was that we used the TDF domains to design the questions, and then we designed the questionnaire in such a way that you could incorporate any end statement as the target behaviour into that, so that you could really hone in on exactly what the behaviour was that you were looking for, and then ask the questions in relation to that. We found some really nice differences in terms, and I guess a face validity in terms of a mean total barriers score. If that was higher, then the use of pH method first line was also higher, so there was obviously, also lower, so that there was kind of a bit of a validation there in terms of knowing that people who perceived more barriers were kind of doing less of the required behaviour. And again, some really nice spots where that tool's been used, and different target behaviours for change, different kind of areas of clinical practice have incorporated their target behaviours into the questionnaire. So we published on this, demonstrated the theory-based approach to the design of these interventions, and there's just a couple of examples of the barriers that we aligned with the TDF, and then behaviour change techniques, and then some of the really nice implementation strategies that we designed. So this one was really to address emotion. There was a lot of kind of people, nursing staff were really worried about being the people that could confirm the position. They weren't allowed to confirm the position through an X-ray, so they were really kind of keen to divert that responsibility to the doctors. So we really needed to kind of tackle some of that. Obviously environmental context and resources, designing and putting these posters up. We had some more kind of more prompts, triggers, cues, instruction on how to perform the behaviour. Some really amazing engaged junior doctors who volunteered to have a nasogastric tube inserted to be able to have these pictures taken and walk through the whole process. So it was a really amazing project actually. And then some other, we designed an e-learning package, and we also had an awareness week, a nasogastric tube awareness week, across the 3 different hospitals, and obviously coded all of the things that we were incorporating to behaviour change techniques, so we could be really standardised and understand exactly what ingredients we'd included in this package. And so we saw some really nice results from this. For each of the hospitals, especially 1 and 2, there was very low use of pH as the first line method at the beginning, and then some really nice changes based on the interventions that we saw in terms of a reduction in the use of X-ray, and then an increase in the use of pH that kind of mirrored each other really nicely. And then in hospital 3, there was just something really interesting where this radiological insertion and check-in, that also was reduced as a result of the intervention period of time. And these findings were significant, and in comparison to a control group, which was found as a retrospective control, which was a limitation of the study. Just tried to really make the most out of the opportunity. And this graph is really nice in that it shows where we'd implemented some of the intervention strategies. And you can see kind of in the January spot there, there was actually very, very poor documentation, which is the green line. And then you can kind of see that it doesn't really seem to be any issue with X-ray first line, or really, and I guess use of pH wasn't really being used at all according to that. But then actually when the guideline was introduced, the behaviour change that happened quite naturally was that everybody started to document. And then we saw that everybody was doing X-ray first line. And so then you can kind of see where the implementation strategies come in, and then this really nice shift with this particular hospital where all information was documented by the end, and then there was a percentage of kind of 15% X-ray use first line, and then you're looking at 90% pH. So it was a really lovely graph to see. And then we did some cost effectiveness work on that, and the estimated savings in the first year were 2.56 million and 1.41 million respectively, given a return on investment of 82%, and this was projected to increase to 270% over 5 years. But then unfortunately I moved to Australia, so I couldn't carry on with that, and they have a different guideline over there as well. So but some of the questions that I had kind of as a result of doing all of that work was, was it the theory-based approach that was the thing that made the difference? Or was it the fact that there was someone really passionate to drive the change, who was, driving in their Vauxhall Golf across the north of England, like, powering through all these clinicians and trying to get them to kind of, buy into what it was that we were doing? Could the same have been achieved if I'd have used exactly the same approach without theory? You know, if I'd have just said, what do you think the problems are? What do you think we should do for solutions? Can we, you know, could that have had the same effect? And how much of each of this, you know, any of this matters? So then when I moved to Australia, I started to, you know, just build networks, do more work in this space, try and, you know, kind of get a better understanding of, you know, how people were using barriers and theoretical frameworks, I guess, to kind of understand and synthesize them and then design strategies, and, you know, did a lot of work to try and support that as well. And then opportunities for advancing the science and application in genetics and genomics appeared around 2016. And a couple of the works that I'd done to kind of really try and understand that space was, you know, obviously to work with different people. So we did some work in genetic carrier screening, some online training programs to increase genetic literacy, and the influences on patient safety behaviours questionnaire was used in that one. We designed a transformative program to introduce genomics into healthcare, which at the time was like really quite new and novel. And then investigating the adoption of clinical genomics in Australia using kind of a barriers facilitators analysis. And that those were all collaborative projects and really great just to kind of get a broad understanding of that particular field. But I was lucky to be awarded a small grant, which really kind of helped kick things off in Australia around achieving behaviour change for detection of Lynch syndrome, which is a condition that predisposes people who carry that gene to a much higher risk of cancer, and a number of cancers as well. And we really wanted to try and understand what referral pathways for these high risk patients look like, whether or not they actually managed to get into genetic services to be able to have the kind of definitive test after they'd received, you know, kind of the news that they had, in this instance, a colorectal cancer. And we use the TDFI process. So in this instance, rather than me being the person kind of running around and doing all the work with the clinicians, there was two other people on the team that had kind of trained up in some of these methods, and they were also had a clinical background as well. So one was a nurse, just finished the PhD, so they had kind of a good understanding of kind of the healthcare context as well. So I was kind of keen to see how all that played out. Just part of this was to start to use process maps to really understand, you know, what these patient journeys look like, where they were falling through the cracks, marrying things up with audit data, and then, you know, really being able to kind of hone in on what those target behaviours are and where the barriers might lie. And quick plug, paper's just out this week for the process mapping paper, and you know, really happy for anybody to pick that up. I think there's lots of useful resources in there for anybody that's interested in using them. But one of the things that we found, so we got a little bit of funding through the Cancer Institute to do a process evaluation of the whole approach. And what we found was that even though there were some significant changes in the practices that we were looking for, not the primary outcome, the process evaluation was the most, I guess, kind of interesting thing about it all, because we realized that trying to bring theory to clinicians at that point in time, so talking like 2016 to 18, so, you know, nearly 10 years ago, it was difficult. We were trying to kind of bring, you know, this behavior change technique means, you know, whatever it means, like, how should we operationalize this? And so it was just really inaccessible for the clinician. And as soon as they saw that the audit data against the process map, they were off. They were just like, we're doing our own thing. Like, we don't, you know, and who are we to kind of try and stop them when they can see that improvement needs to be made? And so there wasn't really that commitment from them to theory. And obviously also, as you can see from the process map, the problem was really complex. It's like 4 or 5 different departments involved in the whole process, and then all the different people and I guess roles involved in that as well. So then we also kind of, from our end, kind of was like navigating the system was really tricky, even for people who were healthcare professionals already. like the stakeholder management side of things, and then, you know, whether or not they even perceived that it was a problem worth fixing. So there was loads of things that kind of came out of that, which got me thinking. And it kind of brings me back to thinking about implementation practice and implementation research, in the sense that with this, everybody wants it really quickly. And as soon as you see the problem, they're off, they want to go and solve it, especially if they've kind of got some audit data or you know, a vague understanding of what the barriers might be, and they're like, yeah, definitely can solve this. So there's a lot of their own strategies kind of coming out in you know, in trying to solve these problems. And then we're there in the background, desperate to do the implementation research, and nobody's adhering to anything. You're kind of like, oh, but I need, at least if you're not adhering, can you just record what you're doing so that we can then just still go and code it and, like, you know, kind of synthesize it in a way that will still help us to advance our understanding in some way. And obviously we all know, you know, that if we can do this, you know, if we can do the implementation research, we can replicate, we can generalize, we can help to sustain, we can scale it up, make it stick. But, you know, just really felt frustrated in the fact that I felt I wasn't really achieving either of these things particularly well. And so one of the things that really got me thinking about was that, you know, these adaptations might be effective. Like, there's so much healthcare professional tacit knowledge and experience. So even though they might go off and do their own thing once they understand what the problem is, it's the fact that they're not recording makes it really difficult to identify, like, the extent to which deviation from the theorized core function of an implementation strategy has occurred, and then also the extent to which they're effective. So that then jeopardizes all of this. So I tried to think about ways to tackle this challenge. And one thing that I really wanted to try and do, I guess more broadly, but also, you know, kind of thinking about it in this context, was capacity building and implementation, particularly in implementation practice from within the health system. How can we help healthcare professionals to use these tools in a way that's user-friendly and not, you know, just giving you a shed load of data that they're then going to have to analyze, and, you know, they don't have the time or the inclination to do that. So we developed a training program called Translate, Training in Evidence-Based Implementation for Health. And we used this to train, in the end, it was seven healthcare professionals across different hospitals in 3 different states in Australia. And they were employed through a grant that I was fortunate enough to be awarded for 0.2 FTE over 2 years. And, you know, so we really made a point of, like, incorporating those funds into the actual grant itself, as opposed to trying to ask the health system for in-kind support. And so we moved through I guess, kind of the TDF implementation process, as I mentioned before. Quite a lot of refinements by this stage, and obviously we were really wanting to make sure that we were kind of teaching people how to use these tools. And we kind of did the training on one day, and then we provided ongoing support over the 2-year period, so that they could essentially send us the data that they were collecting at each stage, but then also we could analyze it for them and then synthesize it in a way that it was given back to them, so that they could go and do the next stage again. And the pink box there, I'll come back to later, but there's, like, a key thing around this barriers and strategies that we did in this particular study. And so we obviously had kind of us guys on one end, and then we had the hospital system and the clinicians and the implementation leads were able to really much more easily access the medical records, work with pathology, genetics. We taught them how to do the process mapping so that they could do that with their clinical colleagues. And then we also did some work with them on the implementation strategy design, but it was kind of they delivered the focus groups with their clinical colleagues in one of 2 different ways, and it was kind of us on the back end that kind of into strategies and then kind of presented the back to them. And one of the really important things is that we had an implementation log, so that we got them to anything different that they noticed, we tried to get them to record that as best as possible. And that was really helpful for the process evaluation of April Morrow, who I've pointed out on the slide earlier, and I'll come back to that in a bit. We had like an email kind of system set up, and then we just kept collating FAQs about lots of different things so that they could go and check in on various questions that could have been asked or answered in the past. And the impact on the leads was that they said, you know, it's great learning. The training day reactions showed high levels of satisfaction. They indicated that they got useful knowledge and skills, and kind of the themes that came out of the analysis of those interviews were that, you know, we really had started to build some health system capacity for implementation. Then the other thing was theory intuition. So we really wanted to obviously tackle these challenges that I'd mentioned before. And so we, in 2015, I had a small, I didn't actually have it. It was a team of genetics counsellors who'd won a small cancer seed grant just to do a pre-post intervention study, which aimed to understand and design strategies to overcome the major barriers familial cancer patients face around communicating hereditary cancer risk information to their relatives. And they used no theoretical framework. I wasn't involved at all. They'd done the study, they'd finished it. And then when, you know, we got to talking about the Lynch syndrome stuff, I was kind of like, oh, this, you know, it sounds really interesting. It sounds like you've come up with a load of strategies yourself. How did you do that? So what we did is kind of went back and looked at the, you know, all the information that Emma, the genetics counsellor, had recorded at the time and coded it back to the TDF. So an intuitive barrier, for example, was loss of contact, immigration, separation, divorce, estrangement, general loss of contact. So we coded that against environmental context and resources. We did that across the board. And then we worked with the team to review and record intuitively developed strategies according to BCT. So kind of linking back to the previous barrier. Their strategy was discussed that some patients have been successful using the phone book, Facebook, or Ancestry.com to get in touch with long-lost relatives. Some patients have even reported BRCA to be the catalyst to contact and reunite with relatives, and it's brought their family closer. So the BCTs we were able to code there were around information about social and environmental consequences, social support, vicarious consequences, like, you know, obviously kind of really understanding it through other people's perspectives, and social comparison. But then finally, we took those resulting BCTs and cross-referenced them against the theory and techniques tool developed by Susan Mickey's group to examine whether or not evidence-based mechanistic links had been established at that point. And that represents theoretical alignment agreed by expert consensus and associations in the intervention literature synthesis. And so then we mapped the links. So, for example, social support practical, advise on, arrange or provide help for the performance of the behaviour. We found that there was significant links there, and that married up with environmental context and resource as a barrier. So what we found is the kind of whole results was that 8 of the 21 BCTs identified were used to address a corresponding TDF coded barrier that had previously demonstrated mechanistic links, and this occurred on about 10% of occasions. So that was the kind of first step. Then we wanted to advance it even a bit further. So April undertook a systematic review and to look at the design, implementation and effectiveness of, maybe it should say implementation strategies. We were still grappling with what you're supposed to call them at the time, but aimed at improving genetic referral practices. And this was a systematic review of the literature. So we found 28 studies that had aimed to achieve this referral practice improvement. And we coded those studies very much in the same way that I've just described with the other study in the genetics context. And what we found was that there was 13% of studies that used implementation science or behaviour change theory frameworks in the design and or implementation of the strategies. There was one full study that fully applied BCTs, but most of them required retrospective coding. The BCT social support practical was most common in successful studies. So we've got a pattern, finally. We've got one pattern. And so because this occurred on 32 instances across 16 successful studies. The BCT information about health consequences was most common in unsuccessful studies. So it occurred on 14 instances across 5. And then 41% of the BCTs in successful studies showed mechanistic links versus 25% in unsuccessful studies, which was also very interesting. So then we moved it a step further and we tried to understand this more in real time. So with the the implementation of genomics in Australia, we were doing interviews with healthcare professionals using a process map to really try and understand from the early adopters and also from those who were kind of not yet doing genomic or integrating genomics, but kind of thinking about the anticipated factors that might affect success. We collected all the information, and then we actually asked them in the interviews, you know, what are your barriers, you know, obviously using a framework, but then also what kinds of strategies could you use or are you using to overcome these problems? So we kind of had a bit more of a, rather than just kind of picking out what strategies we could find, we could actually start to see what do they come up with themselves when we asked them. So we'd done these interviews. They were with non-genetic medical specialists who are eventually going to be having to mainstream a lot of this new practice, coded the barriers and mapped intuitive strategies. We had to do quite a lot of in-depth context clarification and refining of TDF coding, grouped things into overarching themes, and I'll come back to this in a bit. We coded intuitive strategies. We also then designed, because obviously as part of this we were going into application, so we used BCTs to design strategies to address any remaining barriers, and then we also assessed the theoretical alignment, and we're trying our best to really understand the mechanisms of action and you know, we're really trying to hypothesize what they might be. So this is just an example of some of the mapping, but the main thing I wanted to point out here was we found that it wasn't simple enough to just code one TDF barrier at a time and kind of have things as singled out in that way. And one of the things that we'd said about this was, you know, given the relationships, interdependencies between distinct TDF barriers that emerged, overlapping barriers were also grouped according to like an overarching theme, which encompassed several TDF domains. And the allocation of this was really important because it was considered a driver or an influence of barriers that were related to one another at a granular level and indicated the need to consider these barriers together in context when considering strategy development. And then what was really nice was a paper that came out recently that, you know, really started to talk about the limitations of just thinking about barriers and enablers and this kind of, you know, interconnection between them. So I think there's loads of work to be done there, and I don't feel like we've got all the answers, but it's, you know, nice to see that people are thinking about this in a way that, you know, I guess, can we try and solve this problem rather than just poo-pooing, you know, TDF? Like, what can we do to actually just amend it slightly so that it can pick this kind of information up? So this is just one example of a target behaviour area 1, which was around ensuring appropriate patients receive testing. So the grouped barriers was really around gaining belief about genomics. The descriptor was they didn't understand the value of doing the test because they were too busy, takes too long, and they lack natural referral patterns. So we coded this to beliefs about consequences, and one of the intuitive barriers was that they said they need to see the results. If they can see it, they can believe in it more. And then gaining confidence in themselves and trust in others. So this was really, you know, a challenging to gain or grow the knowledge and skills because they were unable to join meetings, to grow confidence, not trained to counsel as a genetics counsellor, a lack of experience, lack of a genetic counsellor support at the offering stage to build confidence. So we coded these to 2 TDF domains, and then some of their intuitive enablers were having a knowledgeable person to answer informal questions, clinical geneticists and genetic counsellors to support, lab experience, gaining experience, informal discussions with colleagues, research project experience, and then access to other physicians with genetic knowledge. So then we were able to map these against BCTs. And through all of this, we looked at the theoretical alignment of all of these ideas that they'd come up with. And one of the things that we also wanted to do, just kind of going back to, thinking about mechanisms of action and how difficult it is to quantitatively measure these things, especially if you're trying to rely on somebody answering a barriers questionnaire pre and post, receiving a particular strategy and seeing if that links to behavior change. We tried to develop a bit of an algorithm to demonstrate what could be happening. So this is what it looks like with kind of just letters replacing the contextual factors. But if we look at it in context, just as an example, we had here the construct of decision making and the distinct TDF theme, memory, attention, and decision making was selected because the clinicians were confused about the process because it was not clear to them. The enabler of clear referral criteria with an informal checklist is linked to the BCT conserving mental resources because it provides explicit guidance. This should reduce the memory, attention, and decision-making barrier, which is the distinct theme, by simplifying the process and enhance their skills, which was the overarching theme, for doing genomic testing by providing clearer circumstances in which to apply genomics in practice. And I guess with this, what I'm thinking is, because it's so hard to assess mechanisms of impact using quantitative methods, if we can standardize the way that we report this stuff and then collect more and more evidence in the same way, then maybe that's the way we can start to identify patterns about what specific strategies are affecting which kinds of barriers, and again then linking that to implementation outcomes around adoption or fidelity or whatever it might be. So in this study, the nature of the retrospectively mapped BCTs and accompanying intuitive strategies we found were largely practical. So they related to continuously updating information provision and support from experienced colleagues or designing new systems and forms. And in many of the instances where no intuitive strategy was suggested and the research team were required to develop the theory-driven strategies, the barriers were more complex. So things like perceptions about organisational expectations to complete bureaucratic processes associated with feeding the results back to patients, or slow return of results to feedback to patients, which manifested in expressions of frustration. And so we thought maybe in some circumstances it might be that theory can be of greater benefit in the design of strategies to address more complex barriers like belief systems or emotions. And with all of this, then maybe there's a way to think about how can we streamline how we use implementation science to support clinical practice change, and do we need to do it for every single thing? Like maybe it's only if there's really complex barriers that we need to provide this more I guess a higher level of expertise in that sense. So then we did a head-to-head trial and a large-scale real-world evaluation to try and compare intuition and theory-based approaches to implementation. And this was a 2-arm trial of intuitive versus theory-guided implementation approaches. And so this kind of comes back to translate and building this capacity in the health system and seeing, can we give other people the tools to be able to deliver theory or intuitive-based approaches, and if we can we test that? So I showed you this diagram before. So in this particular study, there were 7 major hospitals randomly allocated to the 2 trial arms, intuition or theory. We did the process mapping after the training. We did the process mapping exercise, which was delivered by the implementation leads, who were blinded to which trial arm that they were in, and but they all got the same training for the process mapping. And then obviously mapped the audit data against that. So we were able to then, as the internal team, identify the potential target behaviours for change and then present that back to the leads, who then took it back to the clinicians. And then in the identification of barriers to change, there was a theory arm, which had tools that we trained the implementation leads to use to deliver focus groups according to the TDF. And then the non-theory arm, where they kind of just said, what are your issues? What do you think? And then strategy design. What kind of things do you think would fix that? But we tried to make absolutely everything in terms of how all of this was delivered exactly the same, except for the use of the theory. And then we evaluated the effectiveness and the cost effectiveness of these 2 approaches. And so it's currently under review with Implementation Science as the trial itself. But the primary outcome of risk appropriate ensuring that patients went through the entire risk-appropriate pathway in the right way. The theory arm was better, but not significant. And then the secondary outcome, which was risk-appropriate referral into genetic services, was the theory-based arm was significantly better, but there was one larger hospital that was influencing those results. And I guess in this, I almost didn't show you the results, maybe because they weren't too exciting, but also maybe because I think it's more the fact that we've used some really cool methods, I think, to try and think about how we test these things against one another. And that's kind of the bigger learning I hope comes out of all of this. And then we did process evaluation. So I mentioned April. She's got a full process evaluation, but one of the papers was around this bridging the gap between intuition and theory. And I think that's going to be the focus of the journal club that we have today. But I'll give you some snippets of that. So there was 42% of the intuition-based implementation strategies contained mechanistic links previously demonstrated to be significant. In the intuition-based trial arm sites, most frequently observed BCTs were prompts and cues, followed by instruction on how to perform the behaviour and social support practical, which is really cool because in our systematic review, we found the pattern that social support practical was associated with more successful studies in improving referral of these patients in this particular setting. But anyway, so the benefits, I believe, of studying healthcare professional intuition are that linking theory to implementation strategies, even retrospectively, can support the goal to standardize strategies, improve our understanding of the implementation strategy effects, and enhance replicability and generalizability across settings. And demonstrated alignment between intuition and theory can hopefully demystify theory, give the healthcare professionals credit for successful implementation strategy design. All right, you've actually designed something that the theory said should work or has worked in the past if it's been tested. And that's really good for engagement of healthcare professionals, I think, as well. It can show when clinician intuition suffices without theory-based design, highlights some of the additional benefits of theory, particularly for those more complex barriers that we might need to tackle. Emphasizes the importance of documenting strategy design, contributes to the evidence base for establishing and explaining mechanistic links for strategies that lead to clinical practice change, supports adjustments to theory when the theoretical predictions and empirical observations are inconsistent, and maximizes the efficiencies and hopefully advances the science of implementation. So what does this all mean? Well, obviously, I really love the TDF. But apart from that, clinicians design implementation strategies that align with theory only part of the time. The alignment between clinician intuition and theory is largely practical. In many of the instances where no strategies are suggested, the barriers were more complex. In such circumstances, theory might be of greater benefit in the design of strategies to address those more complex barriers. But extracting and coding takes, and I'm sure so many of you will know in this room, particularly Charmaine, I'm going to say, Charlene, I'm sorry. It takes so much time. And so what do we need next? So we've come up with a solution. It's very, very early days. We've got a pot of funding that we're sort of starting to use to build the foundation for Implemate. So I like to be everyone's mate. So this word works really well with me. But essentially, it's a learning implementation system where we would be able to extract information from publications and live projects. And by training a machine through the development of a very detailed ontology, and you might have seen some of the work that Susan Mickey's done in this space, in the health behaviour change space, we might be able to improve the efficiency of I guess, understanding what strategies would be useful in certain contexts for certain interventions. So this would provide timely guidance to professionals with also AI-assisted data analysis. And then all of that information, if we can start to get it in such a way that it becomes much more standardized and I guess sets a precedent for more standardization, we can hopefully start to really learn and integrate expert review and feedback, make sure things are really accurate, but also, continue to ensure that the evidence is updating itself so that we know more and more and more about what strategies are likely to lead to implementation success in any given circumstances. And so we've presented this just as a poster at CERC last year, and we got some UNSW research infrastructure funding. It's about 350 Australian dollars, 350,000. I won't get far with that. We're presenting Implement at the EIE, the Evidence-Based Implementation event, next week. And we've also submitted an ideas grant, and we've connected in with Guillaume and Jana Hastings, who's been, really fundamental, I think, from a data science perspective in developing the health behaviour change ontologies with Susan Mickey. Thanks for listening. And questions or discussion? Oh.
Thank you, Natalie. So we're going to take, you can stay there.
Okay.
We're going to take the questions online using the Q&A function. So if you have any questions for Natalie, please leave them in the chat. And I'm going to, some people in the room, if you have any questions as well, you can ask them. But I'm going to start off with one of my own questions. So you've talked about intuition, right? But it's intuition of whom? So you've worked, I guess, I'm interested about the composition of the clinical teams, right, that you work with.
Yeah.
Was it like, physicians, nurses, managers, like the intuition of which persons, right, essentially in the composition of those groups?
So essentially everybody who was involved in, so what we would normally do is, if we were trying to understand a process, any kind of clinical process that we were trying to support change for, we would first try and understand who's involved in all the different steps, as you, I'm sure, would do. And then depending on who they were, we would try and make sure that we got representation from every single person. So whether that's a manager, an administrator, as well as a nurse or genetics counsellor, oncologist, colorectal surgeon, we would try to make sure that we've got the representation from them. What could be interesting is to try and code who the suggestions have come from. So maybe that's the next step. I'm gonna...
Yeah.
I'm curious about, how do you define or what determines that intuition? And you mentioned at the start of your presentation something about, is it because people are really passionate about something and want things to work, or is it because, like, where does that intuition comes from a place of motivation, of knowledge, of the context and the people in the context, or professional expertise or professional experience? Like, from your experience, from all the research that you've been doing, where that intuition comes from?
Yeah, it's a great question.
Repeat the question.
Oh, I'm sorry. So what was your name? Sorry. Liliana, lovely name. She just asked, where does the intuition come from? Is it because you're really passionate? Is it your clinical expertise? Is it knowledge of the context? And I guess in the experience that we've had where we've tried to formally understand this, obviously we're going in and asking people, say through a process mapping exercise, tell us how this whole process works for you, and how do the roles work, who does what when, what if this doesn't happen? And then it's kind of out of that, sometimes the barriers and then the suggested strategies just fall out, like they just offer them without any prompting. And then in other instances, we've done it where it's been very structured. So tell us, okay, using the TDF, for example, informed question, tell us about your barriers, and then, okay, tell us about some strategies that you think or have already used to overcome this. And I think that in those instances, we're obviously there for a reason. Like, we've set the room up, they've been invited, but I don't know what happens in a more natural world context other than what they tell us in that room as to, whether there's anything else from an intuitive perspective that's happening. But, there are motivated people in the room to be there to talk to us about all of this information, and for the reasons of wanting to implement something new or improve something. But at the same time, there's probably some people that have been dragged there and maybe aren't as vocal, but could have some really good ideas, but for whatever reason just aren't engaged. And I guess that's a whole new question in and of itself, about the kind of engagement of teams in the implementation process and how you foster that. Yeah.
I have some questions online that are just coming in, quite a few. I'm curious if you know or you use specific theories to examine intuition.
Not yet. And I guess one of the things that I've been really wondering about is kind of more on the strategy development side, is somebody, to what extent is the seed of an idea that somebody provides that helps you to develop a strategy versus a full-blown strategy that they've designed themselves. So often we'd have to build on something that they've come up with to then kind of help it to represent a behavior change technique or an ERIC strategy as the formal definition. But in terms of what intuition really means and represents is probably something I do need to start getting into a bit more, and really making sure that that definition is solid and represents what it is that we're looking at. But I guess it really has all come from thinking about that tacit knowledge that people bring to the conversations that you're having to try and solve the problems, because it is based on their experience. And so somebody with 1 year versus 10 years might have a lot less to offer from an experiential perspective. But then at the same time, in lots of other walks of life, they might have, experienced things that help them to come up with brilliant ideas. So it's still a bit of a minefield, I think.
Another question. I hope I'm speaking loud enough for people to hear online. Although we are moving towards evidence and theory-based implementation science, we kind of still somehow need intuition in our implementation practice, fresh out-of-the-box ideas sometimes that are triggered from intuition. So based on your experiences, to what extent do we still need to use intuition in evidence-based implementation? And how do you balance the two?
For me, maybe this is just too basic a question, but at the moment, I don't think it really matters as long as you log it. And then you know exactly what, how it came, what it looks like, how much you had to, engineer it a bit more. But really just getting to the point where, okay, somebody else came up with it, or the theory was used to develop it, or somewhere in the middle, but this is exactly what the strategy looks like, and this is how you define it in terms of a BCT or an ERIC strategy, or whatever other strategies EPOC might be available. Yeah.
Another question comes from Mark Embrett. Sorry, I didn't name the people before, but I'm going to do that in the future. Have you tried combining TDF with the CFIR, so the Consolidated Framework for Implementation Research? And if yes, what are your insights for combining these theories along with intuition?
So yes, yes, we have. And then yes, we've coded in other papers I didn't talk about today, but taking the same approach. The thing that I am not as keen on is the evidence base for the CFIR-ERIC matching is less easy. I guess it's less easy to say there are mechanistic links that the intuitive strategies that have been designed, that suggested, align with. I think more from that perspective, it's about trying to establish these mechanistic links and making sure that we code and log things properly, so that you could do something that's, I guess, a little bit more in tune with the way that Susan's team have done it with the BCTs and TDF, obviously noting that there's limitations there. But in terms of using the CFIR and doing all of this work in the same way, I find it even more helpful to have the other determinant areas, including those individual level factors that affect change. Yeah.
Excellent. Another question comes from Logan Lawrence, who says, thanks very much for the presentation. Could you talk a bit about how you've built partnerships with folks in the health system and making sure that the questions you're asking are also questions they want answered and in a time frame that works for them? As someone who works in the health system, I often see a disconnect between the initiatives we're asked to implement and the actual needs and desires of clinical settings, which leads to low engagement and poor impressions of relevance.
Yeah, great question. So I think the most simple answer is we often get approached by clinicians to support an implementation effort of, whether it's improving something that already exists or implementing something new. So I guess that's kind of a more simple approach to that broader, there seems to be a need because the clinicians are telling us, and this is the grant that we've applied for and being awarded the funding, and that could help with, getting that top-down support in hospitals. But then at the ground, kind of on the ground, the thing that we have worked really hard on, and I guess there's a bit of information in the process mapping paper around the stakeholder engagement, is to present what we understand to be the process with that acknowledgement that it probably isn't that, and the clinicians are going to be able to tell us more about what that looks like in their reality. And obviously it serves a load of different purposes, but it can, in addition to helping to understand whether or not there's a need, and being able to marry your audit data across that and kind of demonstrate that there's an issue in a particular area of that process, it can also highlight that there isn't one. And do that at that early stage, and then you just acknowledge that and say, look, actually, I don't think that this is the thing we should be working on. And doing it at that early stage, there's probably an option to pivot the grant in some way if it is something that's been funded for a particular reason, and you've kind of got the in then to co-design the problem that you want to solve together. Yeah.
There's another question online from Francis Bruno. How do you envision intuition feed into meso macro level changes? Can it be embedded into policies?
Good question. The thing that I'm finding with policy at the moment is understanding, we talked about this the other day, like the smoke and mirrors behind, the high level decision makers. And so what really is the truth of what is going on, and how much are they going to let you see that, so that you have a truthful understanding of what's happening. And then I guess, yeah, you can still use a similar approach. You talk to people, you listen to their views. They may suggest strategies to overcome particular problems that they've got. And from my point of view, as long as you're able to marry that to a framework, and that can standardize things and help you to identify any patterns that you start to find, then yeah, that's probably what I would do. It's just whether they'll let you in.
I have another question. So there's another question in the chat, but before I ask it, so you presented that it appears like the simpler barriers maybe do not require necessarily an extensive theory-based development kind of approach to address, like lack of knowledge.
Yeah.
So are we heading towards a kind of a system where we could look at the TDF domains or the CFR constructs and say, those require more extensive kind of theory-based approaches to address than TDF. So your thoughts around those, and you mentioned emotion beliefs that might be more difficult to change. So
yeah, so I've not kind of like necessarily advanced my thinking on. I think there are these more complex barriers, and maybe we can think about how to make the whole process a bit more efficient if those aren't involved. But I've only found in these few studies that this kind of seems to keep cropping up. So I don't know how much evidence we need, or how we generate more quickly to start to pigeonhole things into this is complex and this is not. But yeah, maybe we should have a go.
A question comes from Sami Mortaz from Ottawa, from the Center for Implementation Research. Thanks for the interesting talk. Curious to know if you have looked into intuition among non-healthcare providers and professionals as well.
As in
their contributions in terms of their intuition feeding into identifying barriers, non-clinicians.
As in patients? Do you mean as
patients or managers or?
So we have looked at it so that one is in the context of implementing a program to reduce unprofessional behaviours in the healthcare setting. And so we did some of that mapping against the CIFA, and that didn't necessarily involve practicing clinicians themselves, but more, I guess, kind of people who are on the ground trying to implement the program. So done some work in that space. I feel like we have done some work in the patient space, but exactly what study it is not coming to me now. But I think it's definitely worth exploring. Yeah, I think patients or members of the public are probably just as able to come up with solutions to problems that they experience in the healthcare system, for example. But I guess then it's just really trying to understand, through applying things like appease, how feasible is it? How much impact is it going to have, and for how many people? And that's something I didn't talk about today, but with a lot of the work that we've done in the strategy design from the intuition perspective, as well as obviously the theory, is presenting those strategies back and trying to understand what the feasibility of that strategy is and whether or not it's going to be worth, implementing it. Yeah.
There's another question on and comments on how keeping from Celine on how keeping momentum for implementation of practices in healthcare is challenging. So I guess that also touches on sustainability, and maybe your thoughts on sustaining momentum and change and sustainability.
So that one really good example from the nasogastric tubes study, so it really has been a champion. The person who I worked with at the time, so talking 12 years ago, still there, sends me a graph every year, tells me, we've had no never events in this area since, since the project. These are all the amazing things that we're still doing, always pushing, always pushing. And so I think there probably does need to be an element of that. With thinking about the precision oncology clinic, which is a very different scenario in itself. We are doing things that are really trying to understand at policy level, what can we do to demonstrate the cost effectiveness of this clinic in routine healthcare, and how do we demonstrate that? How do we demonstrate value? And I guess really that's working with the Medical Services Advisory Committee to try advocating, lobbying. Like there's all of these other things that you kind of need to consider for something like that to ensure that it's sustained. So probably depends on what type of intervention you're thinking about and how far reaching it is going to be and who's involved in it. Yeah.
Maybe a final question for me would be to Logan Lawrence's point around embedding implementation science into the healthcare system. If you could talk about the SPEAR platform and how the supports from implementation scientists work and all that you've set up.
Yeah. So for anybody who doesn't, you probably got something similar in your health systems in Canada or maybe in other countries. But we have kind of partnerships between kind of the universities and the healthcare system that are supported by some government funding, and what our partnership's called Sphere. And we have different platforms, so like clinical academic groups who do, I guess, kind of clinical research in cancer, aged care, mental health, pediatrics, whatever it might be, and some core platforms that kind of sit as a foundation, health economics, big data, implementation science is one of them. So with this platform, we've pulled together implementation scientists who are kind of part of the Sphere partnership. So we've got partner universities, and then actually try to, I guess, open the doors so that more implementation scientists can join the network. And then we've designed a form, which is just a way for people to find an implementation researcher, and then there's like a matchmaking between the researcher and the person who's filled out the request. And then we try and give, I guess, some support to the implementation scientists, particularly the more junior ones who might need discussion about the budget conversation, in terms of a grant, like what kind of support are you needing right now? Is it very practical? Is it, what stage are you at? So trying to, kind of empower them a bit more to have those difficult conversations with, usually quite intimidating clinicians. And I guess, just trying to build more capacity between, through those, so that clinicians are learning more and more about how to apply the tools. In terms of building capacity in other ways, I do think that having more embedded implementation researchers in healthcare should be supported, because then you would have that really nice approach where you can, for example, understand a problem much more quickly. You build that trust with members of the clinical system, and then also you might be able to think about ways in which you can upskill people in a way that isn't really overbearing for them. So can you give them the tools to use, but you do the data analysis, and that's the partnership. And then out of that, you're able to engender the change, but also have all the information to advance the science in whatever way you need to. But the separation I do find really tricky, and ethics.
Well, thank you so much, Natalie. Thank you for being with us all the way from Australia. Pleasure to welcome you. Great talk. And we can contact you by email. People online can find you, and the recording of the webinars will be posting on YouTube over the coming week. So thank you so much.
All right. Thanks everybody for coming.